Thanks for tuning in today. I'm Dr. Nick, the Incrementalist. Join me as I seek out the small incremental changes being applied in other industries that we can learn from and that can be applied in healthcare. Can these changes bring immediate value, but also add up to the big improvements and revolution we need in healthcare? Come along with me to explore the possibilities. My innovative guests from around the globe have used small incremental improvements to achieve their moonshot. Thanks for joining me today, and I'm delighted to be welcoming Dr. Joshua Scalar. He's the Chief Medical Officer for BioIQ. Josh, thanks for joining us today.
Hi, Nick. Thanks for having me. It's great to be here.
So tell us a little bit about yourself. You have an interesting background to how you arrived at this point as a clinician. It's not a typical journey, and I think it bears relevance to some of the things that we're going to talk about today.
Sure. I certainly didn't take a traditional path into medicine or public health, which is to say, my first profession was music. I was a professional saxophone player, starting from a very young age. And in my early 20s, was on tour with a band, and we were involved in a motor vehicle accident, in which I was very seriously injured. And in cinematic fashion, paramedics had to close down the freeway and land a helicopter on it and perform an emergency invasive procedure on the side of the road that quite certainly saved my life and also started me on a journey into a different career path eventually. I would later go to medical school, and after medical school, would sort of take, again, a unique path in my career, which is to say, I divided my training as a physician fairly equally into two parts. The first part clinically in surgery, and the second part in public health. A lot of people don't realize that physicians in the United States can train and become board certified in public health. In fact, I believe there are 10 to 12,000 physicians board certified in public health in the United States. It's actually the third oldest medical specialty recognized by the board. So that has had a tremendous influence in the way I think about problems in healthcare and about prevention specifically. One of the implications for that comes from my experience learning as a surgeon in training about trauma care. Trauma care, which is obviously very important to me based on my personal experiences, has a completely unique treatment paradigm. It's very different from the paradigm that the rest of medical care uses. So for example, if you're a patient and you go to see your doctor, the first thing your doctor's going to do is talk to you. They're going to take an extended history from you. They're going to find out what's bothering you. They're going to find out about the rest of your medical history and your allergies and medications. They'll perform a physical examination. They'll order laboratory tests. They'll order imaging studies. And hopefully, they'll get to know you a little bit as a whole person while they try and address whatever your healthcare concerns may be that day. That paradigm does not translate well to severe level 1 trauma. Car accidents, gunshot wounds, stabbings. Obviously, those patients don't do well if you treat them the way you treat the typical patient. So in trauma, we have a unique treatment paradigm, which is advanced trauma life support. And it goes something like this. The trauma team immediately evaluates the most dangerous life-threatening conditions you might possibly have. If they find that you have one of those conditions, they stop what they're doing and they treat it right there on the spot. Then they move to the second most pressing life-threatening conditions you might have. Again, if they find that you have one of these conditions, they stop what they're doing and they address it immediately. That's a paradigm that's much better tailored to getting good outcomes in trauma care than the traditional medical paradigm. So what does this have to do with our topic today, prevention, public health, and the rest of really my medical career? Well, when you train in public health and particularly spend a lot of time looking at the delivery of clinical preventive services, you're of course accosted with the headlines we see every day in healthcare that say things like the United States leads developed countries in preventable deaths or deaths that are amenable to healthcare intervention. It seems like a new study is coming out every 6 months telling us this. The most recent one I remember seeing was in the Lancet. It basically put the US on par with Estonia in terms of deaths that could be prevented by healthcare. Similarly, a health affairs article just recently published highlighted the fact that 8% of adults in this country get all their clinical preventive services. 8%. It's a shockingly low number. And this is not news to your podcast listeners. It's certainly not news to you. But the way that I personally think about that problem, given my history, is that prevention needs a new paradigm, just like trauma needed its own paradigm. And that's what motivates me. That's what gets me up in the morning. And that's really what the latter part of my career has been about. It's been about developing that new paradigm.
So that's fascinating. I mean, I think it's always a real positive impact in terms of the way people arrive at healthcare to have that sort of personal experience. Obviously, terrible that you had it, but I think it drives a lot of insight and certainly direction. And it's fascinating to me to link ATLS and that urgency to population health and managing this whole sort of preventative care. So tell us a little bit about the company that you're working for. You're the Chief Medical Officer for BioIQ. What is it that they do?
BioIQ is a venture-backed healthcare technology company that is really transforming the delivery of high-value preventive services. And the way we do that is essentially by making those services much more easy, much more personalized for consumers to access. So if you think about healthcare in the United States and how expensive it's become, I immediately think of the billboards that I see on the side of the highway that say 0-minute wait for the emergency department. And we know that people respond to that. People go to the emergency department for primary care all the time with good reason. The emergency department's open 24/7. There's always a doctor in. They have all the laboratory testing services and the imaging services you could possibly need right there waiting for you. There's a 0-minute or a 5-minute wait. And not only that, they took the time to tell you that with billboards and advertisements. This is people voting with their feet for the kind of utilization we don't want them to do. So our response at BioIQ is to make good utilization, high value, preventive healthcare services that convenient, that user friendly, and to bring technology to bear on it to make it personalized and really wring every dime of value we can out of it. And that's our basic philosophy.
So, it's interesting in terms of the sort of process and the steps, and, obviously I focus on these incremental steps. And I think what you highlighted is something, again, a recurrent theme that I hear throughout my interviews is make the right choice, the easy choice. And it sounds very much like that's what you're trying to do. And I'm really curious, how do you achieve that? How do you achieve that same level of ease of access and the right choice to be the easy choice? What is it that you're doing? What are the steps that got you here?
Sure. There are a couple of use cases or examples of really valuable services that are ripe for transformation in this country that we use as case studies to really talk about concretely what we do and the impact that it can have. And probably the single best one is the scenario of at-home testing. So let's talk for a minute about colon cancer. Colon cancer kills over 50,000 Americans every single year. In 2017, colon cancer actually led to more deaths than the opioid epidemic did in the United States. It's a shocking fact because the opioid epidemic is splashed all over the front page of every newspaper in the country. Preventable colon cancer deaths, they're not invisible, but they certainly don't get the same amount of airplay. According to the CDC, about a quarter of people in this country who are at risk from colon cancer have never been screened, not ever. It's a shocking fact, given how much money we spend on healthcare services in this country, that so many people aren't getting such a basic life-saving service. So let's unpack a little bit why that is. One, the traditional model of screening for colon cancer for decades was the colonoscopy. Colonoscopy is a great tool for screening for colon cancer. It's extremely effective, and what's nice about it is it can combine both screening and treatment into a single step. So that's wonderful. On the other hand, colonoscopy is an invasive procedure. It involves sedation. It involves a physician driving a 5-foot-long television camera into one of your private orifices. It involves prep, which people hate, which is to say there are a litany of reasons why it's not going to work for everyone. So one, as a profession, we've had to shift our thinking away from, hey, colonoscopy is the gold standard for this, to, hey, we need other ways to get people screened. That one-size-fits-all approach is not going to reach millions and millions and millions of people. So, good news, there are other ways to screen for colon cancer that are just as effective and are much, much easier for many consumers to use. For example, there are what we call stool tests. Simple 60-second test you can do in the privacy of your own home that is every bit as effective at screening for colon cancer as colonoscopy. These tests have been around for years, and yet they are relatively little used. So let me give you some examples of why that may be. If you wanted to take this test, if you were a person who said, you know, I'm not really crazy about the idea of a colonoscopy, but I would be amenable to getting screened for colon cancer, here's what you'd have to do. First, you need to get health insurance. Once you got past that hurdle, you'd need to find a doctor who accepts that insurance. Once you've gotten past that hurdle, you need to get an appointment with that doctor, which could take you 4 or 6 weeks. Then you need to get yourself to that appointment. You might have to take a bus or a train. You might have to take both. Then you're going to have to sit in the waiting room, quite possibly for an extended period of time, while that doctor is running behind. You're going to fill out a mountain of duplicative paperwork. Finally, you're going to see that doctor. And if you're fortunate enough that that doctor calls this screening test to your attention and has the appropriate equipment to test you with, they're going to turn around and send you home. We don't perform this test in the office for obvious reasons. So then you go home. Then you've got to take the test and get it into the laboratory, which might mean you have to make a trip back to the doctor's office to drop it off. Hopefully not. Hopefully you can submit it through the mail. But you can understand why that creates a lot of completely unnecessary barriers to getting screened. So BioIQ's radical approach borrows from a cutting-edge technology of the 19th century, Sears Roebuck catalog, which is we mail the test kit to you. You don't have to leave your house. And you can return it via the mail. It is the same test kit that you would get at your doctor's office, and it will be processed by the same lab in many cases as the doctor's office would use. But we're cutting all the friction out. We call it cutting out all the soft cost, the little irritations that lead to life and death outcomes. In that approach, we have found that when we go after those 25% of people who have never been screened, we can convert literally tens and hundreds of thousands of them from people who have never been screened to people who have been screened. BioIQ screens over 250,000 people for colon cancer using this exact methodology every single year. It's just an example of trying to make high-value services easier to use, trying to make good utilization the easiest form of utilization.
So for those of you just joining, I'm Dr. Nick, the Incrementalist, and today I'm talking to Dr. Joshua Scalar, the Chief Medical Officer for BioIQ. We were just talking about the enormously pleasant issue of colonoscopies and screening for colon cancer, which shockingly affects and impacts more patients than the opioid crisis. But the opioid crisis today, whilst incredibly important, is receiving far more focus and attention, and yet we have this very poor uptake. Josh, you were just talking about the sort of process and the way that you've adapted this and essentially created a friction-free process, so using existing technology. There was no fancy technology in this. What were the steps? How did you get to this point? I mean, it seems simple in hindsight, but how did you approach this? What was the sort of thinking and the way that BioIQ thinks about each of these problems to get to that point of a solution that gets more people engaged and using the tools that are available to us?
Sure. So I've intentionally made it sound a lot easier than it actually is, of course. The end product should be very easy for the patient, right? You receive your test kit, you send it back in the mail. But we know healthcare in America is never that simple. Things are always more complicated than we'd like. So BioIQ's approach is really to be an aggregator and a facilitator that brings technology and the right constituents to bear on any given problem in healthcare. So let me sort of explain what that means. When you make a purchase on Amazon.com, let's say, you are actually availing yourself of a number of key components, technologies, objects, etc. So you're using a website. That website exists on servers. You're buying a product. That product's been manufactured by a manufacturer. It's being shipped to you by a shipping company. You're paying for it using a credit card. That credit card is backed by a bank. There's a financial system that allows that transaction to occur. And what Amazon is essentially doing is packaging up all of these players into one convenient, easy to use format that allows you to click here and get a widget in the mail a few days later. BioIQ takes that same approach to a lot of the problems we solve in healthcare. So let's continue with this colon cancer screening example. There are a lot of players you have to get involved in order to run a program like this at scale. You've got the folks that manufacture the test kits. You've got the folks that process the test kits. You've got insurance companies who have broad information on who has and hasn't been tested. And let's remember, insurance companies are important in that not everyone goes to the doctor or even has a doctor. So if you want to get to those people, you can't necessarily just go to the doctor, right? You've got to go somewhere else to find them. But you also have to have the involvement of physicians. I mean, these tests require a prescription and oftentimes require clinical follow-up if the test result is positive. You've got to have communications, so you've got to have the ability to distribute things through the mail, but also provide reminders for people, either by telephone or text or email. You can see that there's an ecosystem of components here that are involved in running a population health program that's going to touch hundreds of thousands of people. And BioIQ's role is really to use technology to put all those players together efficiently, effectively, and then generate useful data out the back end that says, okay, here's where it was successful. Here's where it wasn't. Here's what we would do better next time, and sort of wring every dime of value out of a program.
So as you think about that for other programs, that aggregation model, are there other ways that we can simplify this? I mean, there's a part of me that says, why is it a requirement to be a prescribable event? I mean, does it need to be a prescribable event?
Yeah, so now you're going to touch on a favorite topic of mine that may or may not represent the views of BioIQ, but myself as a preventive medicine physician involved in public health is very near and dear to my heart, which is to say we need a preferred path for preventive services in America, right? If we want to encourage good utilization in this country, it won't just be about making consumption easy and convenient. It's also going to be about policy making and what things can we do that tilt the playing field a little bit towards preventive care. Today, we hold preventive services, which are extremely low risk and extremely high value and applicable to extremely large numbers of people, to the same standard that we hold a lot of much more risky medical interventions, right? Interventions that are not intended for large numbers of people. They're intended for people with specific illnesses. And I think that's a mistake in this country. An example I would use that does pertain to BioIQ's business is yet another tool in the tool shed, if you're BioIQ, for making really high value services easy to use, is the massive retail footprint in healthcare that exists in the United States. And some of the biggest players in healthcare are names like Walmart, right? They're on every street corner. They're within 3 to 5 miles of outrageous percentage of the American population.
Right.
And they have a tremendous suite of services that they can deliver. And a lot of what BioIQ does is work to leverage that brick and mortar footprint and get more high value services delivered at more of those locations. So let me give you an example of that. The leading cause of blindness among adults in the United States is diabetes, diabetic retinopathy. It's probably well known to a lot of listeners on your podcast. What may be less known to listeners on your podcast is that this is a highly preventable form of eye disease that really hinges on a simple eye exam. And known to even fewer of your listeners is the fact that that exam is available today at thousands and thousands of retail eye clinics all over the United States. Not just in Walmarts, but in retail optometry outlets as well. And yet, a massive number of Americans who have diabetes don't get this exam. Some estimates are as many as 50% of patients have diabetes, are at risk for losing their eyesight, and yet have not had this exam, or they've gotten it too late. So, what I'm calling for is a preferred pathway, a set of policies and interventions built on those policies by companies like BioIQ that really drive awareness and utilization of these really easy to access services. Today in America, a lot of retail pharmacies are still constrained by limitations on what clinical services they can provide. Point of care testing, evaluation. And I think that really reduces their ability to have the impact on American healthcare that we need them to have. And until we really bring the full power of consumerism to bear on our toughest healthcare problems, I don't think we're going to solve them.
Very interesting. It's this whole concept of pulling the patient in obviously resonates a lot with me, and specifically Leonard Kish, who cited patient engagement as the blockbuster drug of the century back a number of years ago. And I agree with you. I think you and I as physicians already do that to some degree, but how do we spread that to other people so that they can apply the same level of sort of attention and detail? At least I do. I don't know that all physicians do. I spend a lot of time focusing on my own health and obviously my family's health. So it sounds like this is a real sort of pathway forward through small steps, just picking specific diseases and opportunities, and it's very exciting. So, Josh, unfortunately, we've run out of time, so it just remains for me to thank you for joining me. It's been a delight. Thank you very much for coming on the show.
Thanks for having me, Nick. It's a topic near and dear to my heart, and it's been a pleasure.
Thanks for joining me today. Do you have any better ideas, or have you found a small incremental change that's brought about a big improvement in your world? Let's continue the conversation on our hashtag, The Incrementalist, or share with me at Dr. Nick1 on Twitter. You can find more information about the show on our program page at healthcarenowradio.com. And tune in next time to hear my discussions with leaders and innovators from around the globe who've revolutionized their space by using small incremental improvements to achieve their moonshot. I'm Dr. Nick, the Incrementalist, and I'm starting a revolution through evolution.